It looks like we're live. So we're going to go ahead and get started. So welcome to the presentation on health disparities in cancer. So it's my great pleasure today to introduce Dr. Erica Werner. Erica is an assistant professor in the Department of Medicine at Harvard Medical School in Boston, and an assistant investigator at the Mass General Hospital, which is an outstanding medical hospital. She's a cancer epidemiologist whose research investigates how things like lifestyle, behavioral factors, and genetic factors affect cancer screening, markers of cancer risk, and cancer risk and survival. And she focuses primarily on racial and ethnic and socioeconomic health disparities. Erica received an undergraduate degree at Duke, so she's a North Carolina alumni at some point, a master's degree in public health from Yale, and then completed her doctorate at the Harvard Chan School of Public Health in Boston. So for the presentation today, she's going to talk about health disparities in cancer, as I said. So health disparities are differences in health outcomes that are closely linked to things like social, economic, and environmental disadvantage, and are often driven by things such as social conditions in which individuals live, learn, work, and play. So her presentation will describe the racial and ethnic and socioeconomic disparities in the incidence, who gets the disease, and the mortality, who dies from the disease, of the most common cancers in the United States, and opportunities for both prevention and early detection. So without further ado, let me turn the virtual podium to Erica, and I'll be back again at the end with the question and answers. Thank you.
Hi, everyone. Thank you so much for joining me, and I'm pleased to be here this evening to talk about racial disparities in cancer. So, okay, there we go. I see my slides. Next slide. So Daryl gave us a little hint at what I'm going to be talking about and a little bit of the information I plan to share, but here is a definition of what cancer disparities are from the National Cancer Institute, which is differences in incidence, again, which is who gets the disease, prevalence, anyone who has the disease, whereas incidence is new cases, mortality, who dies from the disease, and the overall burden of cancer and related adverse health conditions that exist among specific population groups in the United States. Next slide. So, a simpler way of saying that, here's a quote from the former member of the board of directors of the American Cancer Society, is that disparities are differences that should not exist. Next slide. So when we think about disparities, they can happen across what we call the cancer care continuum. And so that goes from prevention and risk reduction, which includes things like tobacco control, diet, physical activity, sun and environmental exposures, immunization, to screening, which are tests for early detection of cancer, to diagnosis, and the approaches that we take to diagnosing cancer and determining what type of cancer it is, to the treatments that are received, both their whether or not they're received, their timeliness and the quality through survivorship. So we often think of mortality as an endpoint for cancer, but many people will get cancer and will survive it and have long-term, it has long-term implications for their health, quality of life and well-being. And then for individuals that do die of cancer, end-of-life care and palliative care is very important. And so when we think about disparities, they're occurring sort of at each of these points along the continuum. Next slide. So just to reiterate that in terms of the anatomy of a disparity, what does it look like? It can be a death from a preventable cancer or a curable cancer, death from a late stage cancer that otherwise could have been detected earlier and then had treatment that could have prevented death. It can be substandard treatment and care, absence of pain control and palliative care, or inadequate support for survivorship. Next slide. So when we think about disparities, they can happen along a multitude of different axes. So racial and ethnic disparities, which is what I'm going to focus my presentation on today, where communities of color are disproportionately affected. But other dimensions and domains on which disparities occur include socioeconomic status, which is related to communities of color and racial and ethnic minority status in the United States because of systemic racism and other factors, which we'll talk about a bit more, as well as disability, sexual and gender minority status, many different dimensions and domains. But today we're going to talk about communities of color and the disproportionate effect of cancer on these communities. So let's get into some data and numbers. Before I get into the numbers, some of this we've already touched on, but just want to make sure that everyone's familiar with some of the terms I'm going to use, though I will continue to define them throughout the presentation. So when I talk about incidence rates, I'm talking about new cases of a disease. These are people who are newly diagnosed with the disease over a particular time period. Mortality, talking about the number or rate of deaths, again, in a defined population over a specific period. And then we'll talk about survival, which is related to mortality, but it's sort of among people who had the disease. What proportion of them are still alive after often 5 years is the time point that we use, and how does that compare to what we would expect in a population that of that same characteristics, let's say of same age and sex, if they did not have cancer. So here's data from the National Cancer Institute and the American Cancer Society, which shows cancer incidence rates. So this is, again, new cases of cancer by race ethnicity. This is data from 2012 through 2016. And it shows that the highest rates of incidence of cancer are among men as compared to women. And then when you look by race ethnicity, you see the highest rates of cancer overall are in non-Hispanic Black men, followed by non-Hispanic white men, with lower rates for American Indian, Alaska Native, Hispanic, and Asian and Pacific Islander populations. If we look at how incidence rates of cancer have changed over time, two things I want to note before I get into the data of this graph. You'll see that this data only shows Black and white, right? And why is that? It goes back to 1975. And from 1975 until the early to mid 1990s, the national registry that we have for cancer only had those two categories for race. It was Black, white, or other. And so it's one of the issues when you talk about understanding disparities is really you have to have the data to be able to measure them. And for a long time, we could not measure other important groups in the United States. But looking at this graph to orient you, the y-axis or going vertically is the rate per 100,000, so the incidence rates, number of new cases for every 100,000 people in that group in the population. And then the x-axis, or going horizontally, is year. So we'll see that over time, Black males in the United States have had the highest incidence rates of cancer. And that gap between Black males and white males has narrowed somewhat, but there's evidence here towards the end of the graph that that gap is beginning to get larger again. And then for white females and Black females, the rates are very similar. And I'll say that these rates are driven a lot by breast cancer, which is the most common cancer in women in the United States across racial ethnic groups, and the rates of breast cancer are very similar between Black and white females in the US. Next slide. So that was incidence, who gets cancer. If we turn to mortality or death rates, who dies from cancer, we see a somewhat different picture. So again, Black males, non-Hispanic Black males in the United States have the highest mortality rates from cancer, higher than non-Hispanic white and all other groups. Whereas incidence rates between Black and white females are pretty similar. We see some divergence with mortality, where Black females have significantly higher cancer mortality rates as compared to white females, with lower mortality rates among Asian Pacific Islander, American Indian, Alaska Native, and Hispanic populations. But I'll say that this data is aggregate across all cancer sites, and so it can obscure some cancers that are relatively less common overall, but are of particular importance in some racial ethnic groups. And so I'm going to go into that next. Next slide. Oh, wait, before I get to that, this is just showing you similar data on trends in cancer rates. So the good news is that deaths from cancer have been declining over time, and they have been declining in all groups. If we had the data for all groups on this slide, you would see that, though the rate at which they're declining has been different across groups. So despite still having the highest rates of cancer mortality in the US, Black males, the decline in mortality in that group has actually been the greatest and the steepest, so that gap between Black and white males has been closing over time. And similarly for Black and white females, it's closed somewhat, but persists. Okay, now next slide. All right, so I said I was going to go through particular racial ethnic groups and talk about, highlight some cancers of interest that are particularly of burden in those groups. So starting with American Indian, Alaska Native populations, liver cancer, which shows up fairly low in the list of top 10 cancers overall, but has a relatively higher burden in American Indian, Alaska Native populations, where men from this group were almost twice as likely to be diagnosed with liver cancer as compared to non-Hispanic white men. And for women, they're about over two times more likely to have liver cancer and about twice as likely to die from liver cancer as compared to non-Hispanic white women. So liver cancer is an important cancer in this group. Stomach cancer, also known as gastric cancer, American Indian, Alaska Native men are about 40% more likely to have stomach cancer as compared to non-Hispanic white men, and about twice as likely to die from this cancer. And similarly, for kidney cancer, American Indian, Alaska Native women are about 20% more likely to have this form of cancer as compared to white women. So while, breast, colorectal, prostate cancers are the most common cancers overall, these cancers are of particular importance in this group. Next slide. So similarly for Asian American populations in the United States, we see stomach cancer and liver cancer appear as well. So Asian Pacific Islander men are about 50% less likely to have prostate cancer, so it's the most common cancer among men, as compared to non-Hispanic white men, but for stomach cancer, they're about twice as likely to have stomach cancer. And sort of a similar contrast for Asian and Pacific Islander women are about 30% less likely to be diagnosed with breast cancer as compared to non-Hispanic white women, but twice as likely to be diagnosed with stomach cancer. And similarly, that's talking about who gets the disease. We also see disparities for Asian American populations with respect to death from stomach cancer, which is more common in both Asian American men and women as compared to non-Hispanic white men and women. And for liver cancer, but Asian American men and women are twice as likely to be diagnosed with that disease as compared to non-Hispanic white individuals. Next slide. And then for Black or African American populations, Black men are about 1.2 times or 1.7 times more likely to be diagnosed with colon and prostate cancer, respectively, as compared to non-Hispanic white men, about 1.7 times more likely to have stomach cancer, and 2.5 times more likely to die from stomach cancer. And we observe lower 5-year cancer survival rates for most cancer sites if you compared Black or African American men to non-Hispanic white men. And this is seen in prostate cancer, which is the most common cancer in Black men and non-Hispanic white men. For Black women, breast cancer, which is what I do a lot of my research on, breast cancer is roughly equally likely to be diagnosed with in Black and non-Hispanic white women. However, Black women are about 40% more likely to die from breast cancer as compared to non-Hispanic white women. And a lot of research has gone into trying to understand what explains that gap. And then stomach cancer pops up again for Black women, where they are twice as likely to be diagnosed and 2.2 times more likely to die from stomach cancer as compared to white women. And for Latinx and Hispanic populations, we see a mixture. So for some of the most common cancers, like prostate cancer, is about 10% less common in Hispanic, Latinx men as compared to non-Hispanic white men. For breast cancer, we see that risk of breast cancer is about 30% lower as compared to non-Hispanic white women. But again, we see liver and stomach cancer popping up as cancers of importance, where liver cancer is, for Hispanic men and women, they're about twice as likely to have and or die from liver cancer as compared to non-Hispanic whites. Similarly, for stomach cancer and for cervical cancer, Hispanic women are about 40% more likely to be diagnosed with cervical cancer, about 20% more likely to die from cervical cancer as compared to non-Hispanic white women. So we see in these groups this mixture of that the particular disparity varies by cancer site. So as we showed here, breast and prostate, less common, less likely to die, but then liver, stomach, and cervical are more common and are associated with higher mortality rates. And we can talk about what might explain the difference in the cancer sites for different groups. Next slide. All right, so what causes health disparities? Big question that we're not going to totally answer tonight, but next slide. Okay, so when I'm talking to groups about what they can do to help reduce their risk of cancer, and I talk a lot to communities of color, I talk about these things shown on this slide. Be physically active, get your recommended physical activity, which is 30 minutes a day, at least 5 times a week. Limit your alcohol intake. Alcohol, I think, is not often recognized as a risk factor for cancer, but even moderate or light intake of alcohol is associated with breast cancer, for example. Higher intakes associated with liver cancer. Smoking, I think we're all aware of the links between smoking and lung cancer, but it's actually associated with many other cancers, including colon cancer, bladder cancer, pancreatic cancer, and eating a diet that is rich in fruits and vegetables. And, I can say this for cancer prevention. I can also give you similar advice for reducing your risk of cardiovascular disease, and many other conditions. So these are the individual level things. In addition, I would say get routine screenings, get your mammograms, get colonoscopies or other screening tests for colon cancer. If you have a history of smoking, get low-dose CT screening for early detection of lung cancer. These are all the things that are sort of within your individual control to try and manage and reduce your risk of cancer. And they contribute to disparities, but I wouldn't say that they're the cause of disparities. We'd have to go a little further, not a little, significantly further upstream to try and understand why might these behaviors be differential across groups? What are the social, policy, economic factors that contribute to differences in someone's ability to maintain a healthy diet or to be physically active, or their access to screening and their ability to get it timely and regularly. So next slide. So when we think about causes of disparities, they are, like I said, more upstream, root causes, racism, discrimination, downstream, healthcare costs, income inequality, differences in social determinants of health, which contribute to some of these health and lifestyle behaviors that we're talking about, historic injustice, the way that discrimination and racism might manifest in terms of healthcare quality or access to care. These are all very important. Next slide. So here's this model. This is from the World Health Organization, and it's their model for social determinants of health. And it kind of puts together what I was just describing, that disparities are being caused at multiple, both micro and macro levels. And if we have a mind towards how do we reduce disparities when we're talking about populations, right? Not just individuals who you can say, eat better, be more physically active, but how do we improve the health of populations? The way to do that is to take a broader and wider lens. So it starts from the socioeconomic and political context, from governance, policies, both economic and social, public policies that determine the quality of education and health resources and access that people have, culture and social values, through that feeds into socioeconomic position and the extent to which socioeconomic position is associated with other characteristics of an individual, like their gender or their race and ethnicity, and individual characteristics like education, occupation, and income, which to some extent are driven by this broader socioeconomic and political context. Those structural determinants feed into what are intermediate determinants of social determinants of health, which are the things that we often focus our attention on: the material circumstances, including your living and working conditions, food availability, behaviors and biologic factors, so both physical activity, smoking, diet, as well as genetic predisposition that might modify someone's risk of cancer, of worse outcomes from cancer, through psychosocial and mental health factors. And also the health system sits within this. So we have to recognize that the health system is affected, right? It's a part of our larger social and economic system, and so is affected by all of these upstream characteristics. It affects both the access and the quality of interactions that people have once they're within the health system. That feeds into the actual impact on your health and well-being, which then has a feedback loop into some of these upstream things, right? So if you become ill and disabled, that can impact your socioeconomic position, which then feeds back into your material circumstances, behaviors, and biological factors, for example. So next slide. So I just wanted to take an example of how we go from something macro, a couple of examples of how we go from something macro to ultimately, a cancer endpoint. So this map here shows a redlined neighborhood, a city. This is a map of Chicago, and it shows something called redlining. So redlining comes from the development by the New Deal, which happened in the 1930s, and it was a process by which the federal government created maps of metropolitan areas in which they zoned different areas, and they were color-coded, hence the name redlining, either sort of green, yellow, or red. And red areas were areas in which it was considered to be too risky to provide mortgage insurance and therefore support mortgages. And places that were redlined were disproportionately, almost always, communities of color, particularly neighborhoods that had large populations, or not even large, had even modest populations of Black or African American individuals. And so through this process of redlining, it made it very hard for, nearly impossible for families of color to buy homes, even in neighborhoods that were predominantly communities of color, and certainly not in neighborhoods that were predominantly white. And so, because of this policy, it had a long-term impact on the ability of families to build wealth, which led to differences in socioeconomic position and socioeconomic status. It created differences in material circumstances, so the neighborhood environments of these neighborhoods that were historically redlined as compared to neighborhoods that were coded as green or yellow on these maps diverged, such that poverty became was disproportionately concentrated in areas that were redlined. This could have a long-term impact on both behaviors and biological responses. So just one example I put here was stress, and ultimately a higher risk of cancer could ensue from this. All right, next slide. And this is just an example of a publication that sort of went down the path that I was just talking about, that looked at historic redlining, neighborhood characteristics, and cervical, breast, and lung, and colorectal cancers in Massachusetts. And they did find that neighborhoods that had been historically redlined had higher rates of late stage diagnosis for breast and lung cancers even today. So showing that this historical injustice has long-term consequences for cancer and other health outcomes. Next slide. And I'm going to skip this one. Keep going. Keep going. All right, then I just wanted to go through an example of acute lymphocytic leukemia. So leukemias are the most common cancers in children. They represent about 30% of all childhood cancers. The peak incidence is between age 2 and 5 years of age, more common in men. And acute lymphoblastic or lymphocytic, they're the same. The terms are used interchangeably, is about 5 times more common than the other subtype of leukemia. Next slide. And so if we look at the incidence of acute lymphocytic leukemia, this graph is showing you the incidence rate, so new cases of disease by race ethnicity. The different colors are different racial ethnic groups, and then the horizontal axis is age at diagnosis. So it's just showing us again that incidence peaks at young ages and sort of declines over time. But you can see here that this in brown is shown Hispanic individuals of any race have the highest incidence of acute lymphocytic leukemia across all ages. So even though it's more prominent in young children, even at older ages, we see this persistent higher risk in Hispanic populations. Next slide. And when we look at survival, thankfully, survival from childhood cancers is relatively high. So for leukemia, this is all leukemias for children. It's about 87% are still alive after 5 years. And for young adults or adolescents, it's 73%. So it's pretty good, particularly for children. But then when we look across racial ethnic groups, next slide, we find that there are disparities. So for Black, Hispanic, and Asian populations, for children, we see lower relative survival as compared to non-Hispanic white populations. Same thing for adolescents and young adults, where Black and Hispanic children have lower survival as compared to non-Hispanic white children. But we don't see, there is a difference that persists even at older ages, but it's not significant statistically. Continue. So when we think about what are the factors that are feeding into this, this is the proximal, so not the macro, social policy things. We could talk about what the social policy factors might be that contribute to these proximal contributors, but we know clinical trial enrollment is one thing. So clinical trials are a very important method for treatment, early detection treatment of childhood cancers. And there have been gaps in enrollment between children and adolescents and young adults, as well as racial disparities in clinical trial enrollment. And this isn't just seen for childhood cancer trials. We see this for adult cancer trials as well. There's more advanced disease at diagnosis, which suggests, later presentation and later detection by the healthcare system. So for both Black and Hispanic patients, they present with more advanced disease. And then for leukemias, not necessarily just for ALL, but for leukemias and blood cancers in general, stem cell or hematopoietic cell transplantation is an important treatment, and access to this type of therapy is less common for racial and ethnic minority populations, both in terms of the ability to find a donor, as well as just ability to get the procedure. And we've also seen that even when the transplant does happen, we see higher risk of treatment failure and potentially higher mortality after transplant in Black and Hispanic children. Next slide. So just to end, how do we eliminate? What can we do? Next slide. So this is going back to that WHO model that shows that if we're going to attack health disparities, we have to do it in a multi-level way. And that goes from policies that help try and reduce the vulnerabilities of disadvantaged people, that help reduce exposures among people that are disadvantaged because of factors, upstream factors, and that help to change those upstream factors that lead to the differential distribution of these harmful exposures and vulnerabilities in, for example, here in the United States, communities of color. Next slide. And I won't go through this, but this is just showing for each sort of level of intervention, what are the types of policy reforms that could be implemented to try and reduce disparities, both at a universal level where it's an intervention for everyone versus a selective approach where you focus on the most disadvantaged populations. Next slide. And this is just to bring us back to that idea of the cancer care continuum. When we're thinking about implementing interventions, we need to think both of the upstream, and then when we get to the healthcare system itself, keep in mind each of these phases of the cancer care continuum and intervene at each point. Next slide. And so, I used to work at the National Cancer Institute, and when I was there, the director of my division used to say this quote a lot, and it stayed with me. Knowing is not enough, we must apply. Willing is not enough, we must do. And it's really that a lot of the things that could potentially reduce disparities are not a secret. It's really the will to make changes and implement them. So thank you so much for listening to me speak today, and I'd be happy to take a few questions.
So that's great, Erica. Wonderful talk. Very in-depth, detailed analysis of health disparities. So while we're waiting for some questions to be posted from folks who are listening, wonder if you'd comment from a more personal level. Has cancer affected you or your family, and what's your experience been? Because obviously we're all doing this for Balakura because we want, we're passionate about cancer research and trying to support the mission of the organization. So can you put a little personal twist on this and tell us how it's affected you personally?
Sure. My mother died of cancer. She died of lung cancer when I was 15 years old. So it's, cancer has had a huge impact on my life as a result of her passing and her loss. And I've certainly lost uncles and aunts and others from various types of cancer. So yeah, it's played a huge part in my life.
So is that why you ended up going into a research field that focused on disparities in cancer, or?
It's certainly part of it. Upon losing my mother, I definitely felt a strong need to do something to have an impact to try and prevent death like her from occurring. Initially, I thought that would be as a physician. And ultimately, I decided, direct patient care wasn't for me, but I really was interested in understanding the causes, the why on a population level.
Right. Very good. All right, so we have a question from Matt. So why did it peak with Black males in 1995?
Are we talking about incidence?
Yes, I think
Cancer?
you referred to one of your earlier slides.
Yeah. So it has to do with screening and two things: screening and smoking. So I'll start with screening. So we introduced more broad testing for prostate cancer in the mid 90s. And so what happens is when you introduce a new screening test, there are a whole bunch of people that actually have the disease walking around. They don't know that they have the disease. You start testing them. You find all of those cases, right? So the incidence of the cancer goes up for a while. And then once you've exhausted that pool of people that had the disease and didn't know it, the incidence comes down. And so some of it has to do with screening for prostate cancer being introduced. And then in addition to that, smoking rates have been declining. And so there's a big lag between when people smoke and when they develop lung cancer, right? So as smoking rates declined, it took 20 years for us to start seeing that in the declines in incidence of cancer. So smoking rates declined. We started in the mid 90s to early 2000s to start see declines in incidence rates of smoking related cancers in men. And there's a lag for women. Women started smoking about 10, 20 years later than men. And so their incidence rates continued increasing.
Right.
Thank you.
So Emily, who actually gave a talk earlier in the day, Emily's a medical student in Denver. She talked about women's health. So she's asking if you could change one thing about education of healthcare workers, doctors, nurses, other ancillary healthcare professionals, to reduce health disparities, what would that be? So so if you could get your message into the medical curriculum of future professionals, what would your message be to them?
Yeah, I think it's important for physicians and healthcare professionals to know that disparities exist. I'm often surprised when I talk about disparities that many people are not aware of them. So first, you have to know that they exist. And two, I think that then follows an awareness of trying to understand and be cognizant in all of your interactions, how might bias, how might disparities be operating here. So, I think one thing we see in terms of the healthcare system is lower quality of care for communities of color. To some extent, that's being driven by differences in health insurance, where people of color are seen. There's an amazing concentration of populations of in a small segment of the healthcare system. So really trying to understand that, be aware of it, and questioning how bias might be operating.
Okay, and so Susie asks, are there examples of programs, I guess societal programs or public health programs or institutions that have been able to effectively reduce health disparities, either in cancer or other health disparities? Are there good examples of things that have worked that we should be kind of looking at as as the way forward?
Yeah, I think there are. There are some examples. One that I'm familiar with is patient navigation programs. So what we find is that when someone is diagnosed with cancer, or even before they're diagnosed with cancer, they're being screened for cancer and ultimately diagnosed with cancer. That process of trying to navigate the healthcare system is confusing for everyone, right? It's confusing for everyone. And then particularly if you have fewer resources, it's maybe particularly daunting, and there may be additional barriers for you. And so having someone, I mentioned at the end of my presentation, I worked for a director, and he said that quote a lot. He actually created the first patient navigation program at Harlem Hospital, where they had tremendous disparities and very high breast cancer mortality. And by introducing navigators, they were able to increase the proportion of women that were receiving timely diagnosis, receiving timely treatment, and ultimately lower the mortality. One of the challenges is that patient navigation, we know it works, but there aren't really good models to pay for it. So often when hospitals have a patient navigator, it's being paid for by a grant, and it's not reimbursed by insurance. So this is a place where like policy could really help to try and reduce disparities.
Okay, so Emily asked another question. So what do you think is the key for regaining trust of BOPOCs that have been marginalized by the medical system?
I mean, I think it's for the medical system to do better.
Yeah.
Like, I mean, I think what often I hear this all the time, like there's mistrust and like, why aren't people participating in clinical trials? Well, it's because they don't trust the healthcare system.
Yeah.
Why don't, disproportionately communities of color trust the healthcare system? Because they've been abused by the healthcare system, right? Because there's been a history of abuse that didn't end. I mean, I think the way in which people interact with the healthcare system has improved a great deal, but there's still lots of evidence that women, particularly women of color, it takes them significantly longer to be diagnosed with conditions as compared to other groups. They often have to sort of fight to be taken seriously. So I think some of this, if we want to increase trust, we have to do the work ourselves to make our systems more responsive to people of color.
Yeah, I also think, just if I can reflect on that, I think a lot of it is also related to the healthcare providers. And I think, for example, we know in medicine that there's a paucity of African American physicians, Hispanic, Latino physicians, and I think people tend to feel more comfortable trusting individuals who are like themselves, who they can relate to. And I think if you go to a hospital where the doctors are all white guys, older white guys, and you're an African American female, I mean, there's just not going to be that trust there. And so I think many of us, particularly at NIH, are working on trying to build that pipeline. Trying to work hard to reach out to underrepresented scientists and medical students, and get them to to continue and devote their career to serving underprivileged populations. So let's see. Susie asks, so you discussed race and socioeconomic status. Can you describe other types of disparities? So other than race, ethnicity, and socioeconomics, what are other examples of health disparities that exist?
I think that there's a growing body of work that looks at sexual orientation and gender minority status. So, particularly of growing importance now is understanding how trans individuals are being treated by the healthcare system, and that their personhood is respected and that they receive the appropriate medical care. There's also, I think, a lot of evidence to show that people with disabilities, cognitive and physical disabilities, face challenges in terms of access to care and quality of care. So I would say, I think when you think about disparities, if you can think of a socially or economically marginalized population, generally that translates into health disparities.
Right. So, we had a session earlier today on COVID, and this question comes in from Susie. So how has or will the COVID pandemic affect cancer health disparities? And it's interesting, as you well know, COVID disproportionately affects African Americans, Hispanic, Latino populations, both in terms of incidence, prevalence, and severity. So more of the bad outcomes occur in those populations. So just as in cancer. So how talk a little bit about how those two things intersect in a unique way this year.
Yeah. So COVID-19 has changed the world, and it's really affected our healthcare system. I'm doing some research right now on the intersection between COVID-19 and breast cancer screening, diagnosis, and treatment. And what's happened is that, particularly at the peak of the pandemic here in the United States, many healthcare institutions were closed for routine procedures and like screening. So mammography rates were down, something like 75% compared to previous years. Colonoscopies have been down. Lung cancer screening is down. So people have not been receiving screening, and so there's this backlog, right, of screening that should have occurred that now needs to happen sometime in the future. And similarly, to a lesser extent than we saw for screening, but we've also seen declines in treatment. So people who have been diagnosed with cancer have had their treatments changed or delayed as a result of concerns about risk of COVID-19. And so when we think about this in terms of health disparities, there's a few impacts. One is that communities of color have been disproportionately impacted by COVID-19, both directly in terms of risk of the disease and mortality from the disease, as well as the economic sequelae of the pandemic. There's been mass unemployment, food insecurity, and that has been disproportionately borne by communities of color, which we would expect to impact health and cancer outcomes. And then the missed screenings that could, if not caught up, could lead to missed or delayed diagnoses of cancer. Again, we might expect that to be disproportionately borne by communities of color. And so, I think that as healthcare institutions, we have a lot to do to try and get people back into care safely and in a timely fashion.
Okay, so we have time for maybe one more question. Susie asked a great question. Actually, I was going to ask this question. So, you talked a lot at the end about, the macro, and I guess, the question. So, if you were president for a day, what kinds of changes in either legislation or insurance rules or whatever would you propose or try to get through Congress in order to try to fix these health disparities? It's interesting. I heard one of your colleagues, David Williams, talk on this topic, and his case was that it's really all about socioeconomic changes, and Ken Olden gave a talk at NIH last week where he basically concluded the same thing. So is it all socioeconomic changes, or are there things that policymakers can do to fix this problem?
Well, I think that socioeconomics are driven by policies to some extent. They're not independent. So I think that there are ways to reduce the impact of lower socioeconomic status on health, right? That could be through universal health insurance, right? Where having a job that provides high quality insurance is not a requirement for having good access to healthcare, right? That's one thing that would go a long way. And we have seen that the Affordable Care Act and the expansion of Medicaid has demonstrably reduced disparities in places that expanded Medicaid. So that's a place where we can see policy working to reduce disparities. Some of the things that in terms of like insurance coverage, I mentioned patient navigation, not covered by insurance currently. And so healthcare institutions are struggling to try and provide these services to vulnerable populations. Insurance coverage for that would be amazing, as well as, ensuring that I think a lot of the protections of the Affordable Care Act continue. Yeah.
Yeah, no, that's exactly it's a perfect answer. So with that, so again, we really appreciate your taking the time to do this. So let me just remind people that we still have a few more hours left. So there are several ways you can donate. You can go to our website, the Bailacura, www.bailacura.org site, and there's a donate button. You can donate that way. You can go on this strange URL that I've probably read about 20 times today, but I'm going to read it again: https://bit.ly/32JQZ9R. I don't know how they come up with this stuff, but so you can go there and you can donate. And I think you can also text to give Bailacura. You can text the words "Give Bailacura" to 44-321 and donate that way. And again, we're all doing this because we want to, do things to support the kind of work that you're doing, Erica, and others at major universities and across the U.S. and elsewhere. And it really does make a difference. The more money that goes to basic research, understanding things like health disparities, the more lives we'll save, and the better off we all will be. So again, thank you so much for your time. And if we have any more questions, we'll have them reach out to you directly, if that's okay. And I think we'll end there. And thank everybody for attending.
Thank you, Erica.
Okay, great. Thank you all.